Good evening to Aging with Community and Grace. Today was definitely a day. Not necessarily a bad day, but just a really super busy day. You know how you have one of those kind of days where you have it exactly planned what you plan to do, and there's so many interruptions, so many different um, issues that may come up that you keep getting taken off track. So a lot of my to-do list either came home with me or it's going to get pushed to tomorrow. Did have the care plan that I had intended. So that part was good. I feel like it was productive. One of the one of the things that can be tough about a care plan, and when we talk levels of care for assisted living, the level of care is based on whatever individualized needs that we see a person has. There is no one size fits all. We take all of their care needs and plug them into the computer. It gives us a number. That number equates to a dollar amount. And what someone may have included in their level three may not be what someone else has included in their level three. It just depends. This particular person jumped up 3 levels. Pretty significant change of condition. Um, so it can be tough when you're talking about, for one, the amount that's going to be added to their bill. Um, most elderly people. Oh Lord, I'm about to choke. And I didn't bring my water over here. Or on a fixed income. Um, hold on, you're gonna have to walk with me. So, we don't take it lightly when we're talking about adding. But the level of care is the level of care. Sorry, you got to go through the darkness with me for a second. Um, and you can never discount the level of care. It is what it is. Excuse me. So we discussed it with the family member. Um, I also included PT therapy to be there and speak to the residents' progress. And unfortunately, this person was not making very much progress um, through his therapy. No fault of his own. It's just the way it is. So instead of forcing a resident to keep pushing beyond their limits, then we look at what other services could we potentially um, put around them in order to give them some support. Palliative and hospice came into play. Palliative can be like the step before hospice, meaning it's symptom management. So let's say if pain was your issue, then that's what they would try to manage to make your life more productive and comfortable. But if it's more than just symptoms, where like this particular person, it's the total care of him, um, hospice is the next best step because it gives a more um, focalized sense of caring for him. So it brings in extra services, nurses coming in, extra caregivers coming in to shower. Um, and I think I said this earlier, sometimes there are people who graduate off of hospice. And if that should happen, which would be great if that did happen to this person, then we would request for PT and OT again. And maybe it's just a matter of they just needed more time to recover from their last couple of hospital stays. Whenever anyone goes into the hospital, it doesn't have to be just an elderly person. When you spend days, weeks pretty much in bed and not getting up and having much movement, they call it deconditioning, where you're just weaker. You're not getting up, doing the same movements, walking around, getting yourself up and going to the bathroom. So it throws anybody for a couple steps back, and then it takes some time to work back up to either your original base level, or sometimes it creates a new plateau for you. So either way, the family member was open to it, so that was good. So my goal is to have a hospice liaison step in, speak with the family. We're still going to let his therapy run to the end of its course. And upon therapy's discharge, the plan is to bring hospice in, have them ready to step in. So I feel good about that. It also helps to be able to let the resident age in place and remain in the community. So, and the good thing is, I mean, this person, he's not a Hoyer lift or anything like that. He doesn't have any, stage 4 wounds, and we'll have a whole discussion about wounds on another day, because that does factor into a lot of things. So that went well. I was able to get the TB injections in for the new hires, and started prepping for the nurse practitioner's visit for all the residents for tomorrow. Had to investigate a couple of incidents. Sometimes that can take quite a bit of time, and then trying to find interventions to put in place for the incidents. I'd say the most significant incident that happens in long-term care is falls. A person newly moving into assisted living, 9 times out of 10, has a fall within the first 24, 48 hours. They're trying to get used to and get acclimated to their new surroundings. But even beyond that, a lot of times when we have someone fall, our first inkling is to either check their urine for a UTI. Everybody wants to blame it on the UTI, and sometimes that is the reason. Or we try to get PT and OT in to assess them, see if they need some strengthening. Beyond that, we really have to be like an investigator to find out what is it that's causing the falls. Is it that they're having pain, and now we need to establish a pain regimen for them to make them free from pain? Are they having neuropathy so that then they can't even really feel their feet, and we need to get them a medication that can help to stabilize them plus give them therapy? Are their shoes not fitting very well? Are their shoes old? Do they need better fitting shoes? Are their toenails too long so that maybe it hurts when they put their shoes on, so they opt not to wear shoes, and they're trying to walk around in either bare feet or socks that are non-skid. We like to have something that's got like grippers on the bottom of their socks so that they're not slipping and falling. Or is it a cognitive thing? Are they starting to be forgetful more than usual and not grabbing their walker or rollator or getting in their wheelchair? And so they're getting impulsive, wanting to get up, and they're falling because they're not strong enough to walk on their own. Are they, let's say in the evenings, they're starting to get hungry, so they start trying to get up because they want a snack. Well, then we can put in place as an intervention, provide them an HS snack, a snack at bedtime. How many of us grab a snack at bedtime? So it could be that. It could be that they're thirsty, they have to go to the bathroom. It could be that they are trying to remain as independent as possible, so they're reaching for things. And reaching for things while sitting in a wheelchair is one of the causes for how someone either slides out the wheelchair, ends up on the floor, or topples over. Is it a blood pressure issue? Some of you may have had experiences where you sit up out of bed and you feel dizzy, and then you stand up, you feel dizzy. That's called hypostatic hypertension or hypotension, to where your blood pressure drops down every time you change position. So sometimes when you sit up from bed, you need to sit for a few minutes and let yourself get acclimated. Then when you stand up, you don't immediately just stand up and start moving. You need to stand up and just hold on until you can get acclimated. So then we may need to have the provider do a review of medications to see if maybe they have too much blood pressure medicine, maybe they don't need the blood pressure medicine anymore, or we look at all the different factors. There are some people where their blood pressure can go too high when they go to move or go to stand up and walk. So then they may have parameters placed by a cardiologist that will say, they shouldn't be up and walking by themselves if their blood pressure shoots up so high. So there's a lot of different things that we have to look at. Is there a rug on the floor? Is the rug attached to the floor, or does the rug move every time they get up to move? So I provide my staff with a list. The latest list was 101 fall interventions, so that it can give them ideas, because it can't just be, oh, we're going to check on them more often. You can fully intend to check on someone more often and easily get pulled in another direction. So that's really not a successful intervention. And plus, if it's not really getting to the root cause of why they're getting up, why they're falling, I don't care if you did check on them every 30 minutes, every 15 minutes. It still isn't, it's not addressing the issue at hand. So I forgot how I got on that tangent. I don't know. But anyway, I was investigating things. So that was one of the things I was investigating with. We're going to do some transfer training for the care staff. Not everybody, especially in an assisted living setting, has formal training, or you could have new caregivers that have just started. They may not be aware of the proper body mechanics that you have to do in order to assist someone from a sitting to standing position. Like, for example, when I was an STNA, we had to go through training, we had to practice, we had to prove and show that we understood and knew how to transfer someone. One thing you should never do is grab someone by their hands, their arms, and go to pull them up. That's not very stable. You can yank somebody's shoulder out of socket, or their elbow, or you can cause bruising on their skin. Not that anyone was intending to harm them, but it could very well be that they're just moving them in an unsafe way. So we're going to do some transfer training to make sure that they know how to transfer someone safely, protect themselves, protect the resident. Caregivers can suffer back injuries by improperly trying to lift someone. So we want to make sure that they're doing the right things. What else was happening? I think that was probably about it for today. So today's a short one. Tomorrow is Friday. Hopefully all will go well tomorrow. And I'm going to finish up a little work that I had to bring home. Unfortunately, it does not always stop there at 5 o'clock. So I'm going to get to doing some charting and preparing for tomorrow. All right. I hope you all have a good evening. Thank you for everyone who has liked and or subscribed to my podcast. Please continue to share this with anyone that you think this would be helpful for. A couple things I meant to say yesterday. When I talked about, well, maybe I didn't, but I'm going to talk about it a little bit now. So some people deal with loneliness living in an assisted living or a nursing home. One thing that the residents like is to see children. When we had Easter, so there's a school not far from our community, and we provided Easter eggs to hide, around the front of the building. And the children came over. We had the residents sitting out there, and the children came over and hunted for Easter eggs. And it was enjoyable for the residents. if you have, let's say, teenagers looking for volunteer work, going and visiting and sitting with a resident is a great way to learn about elderly, to feel comfortable around them, to talk to them, um, and to earn volunteer hours. So if you have anyone, any young people, or let's say if your church has a church choir for the youth, find your closest nursing home or assisted living and let them sing and perform for the residents. That is a form of entertainment that seems to feed their souls very well. Um, you can volunteer by bringing, plants that need to be planted. That's a good activity for the residents. If you want to come and help them paint, if you want to read to them, anything that you can think of that could potentially brighten someone's day. Mother's Day and Father's Day is coming up, so delivering flowers to your nearest assisted living or nursing home is always a great way. Memorial Day is coming up, and we tend to try and honor our veterans. So your local lodges, or just, however you would like to, if you want to come and, donate flags or read a poem or a pin or a lapel, something to go on their shirt to honor a veteran. Um, these people have served um, during some really serious war times. So we like to keep their spirits up, that we appreciate them for everything that they've done. So think of those things, brainstorm ways that you can go and be a blessing to seniors in your community. Because again, it really does take a whole community to um, be able to care for these people. Some have families, some don't. Some family members choose not to participate, or even a family of 12 children. Somehow there's always, I won't say always, but there's usually one person unofficially designated to carry the burden. So we want to just jump in and help as we can. So please reach out and find your nearest seniors to be a blessing to. All right, you all have a very great day, and I will most likely see you tomorrow.